Phase 2's goals are primarily to increase shoulder range of motion and improve shoulder girdle strength. We still need to be mindful of the healing capsulolabral tissue and avoid any stretching beyond active range, especially into abduction and external rotation. Active assist range of motion exercises should be continued from phase 1, but now can be progressed into greater range. Supine is best as it stabilizes the trunk and the scapula and helps to prevent that compensation. Patients can move into flexion, scaption, they can come into abduction, best done from that shoulder flexed position to start with. And they can also start to work into external rotation from an adducted shoulder position. All range of motion exercises should be done within the limits of pain, and patients should be instructed not to force or stretch purposefully into end range of motion. So in addition to the stick active assist range of motion, patients can also begin doing things like wall washing or wall walking at this stage. You want to ensure when your patient's doing this that they're doing it with proper posture and that they're not starting to hike the shoulder up and go into that protracted position when they start to get into those difficult phases. So you've got to teach them how to feel shoulder blades back and maintains that stable position. These exercises can be progressed easily by having the patient maintain where their arm is, and just changing the position of their body will change the angle of elevation that they're working in. Patients can progress from active assist range of motion to active range of motion when they can perform these exercises without pain and with good technique. So pendular exercises are still suggested in phase 2, but the way you can progress them is still have your patient unweighted and moving in that dinner plate circumference, but you can add a little bit of scapular input. So you can have the patient go into a little retraction and still try and stay relaxed. Or you can do the opposite and have them first position in scapular protraction and do the same motion. Strength exercises in phase 2 should begin with a continuation of resisted isometrics, but now the patient can perform these in standing with the arm in a neutral position. First steps are always to establish excellent posture and set the scapula into a retracted and slightly depressed position. The patient is then instructed to hold this posture while doing the shoulder isometric exercise. We are allowed to progress to isotonic strengthening during phase 2, but before adding joint movement to the exercise, you can progress the isometric exercise by changing the angle you position the arm in. For example, the arm can be abducted to about 30 degrees and perform the isometrics in this position. The same can be done by changing flexion, and even the amount of external rotation can be increased if the patient can perform the exercise pain-free while maintaining proper scapular positioning. So early progressions to isotonic strengthening should be done with the arm moving in short lever, short arc patterns. Long lever exercises like this should not be performed at this stage as they place far too much force on the healing tissue. Exercises like this, where the elbow's straight and there's a handheld weight, should be discouraged, as well as long lever exercises with tubing. So instead, good choices would be something like this, where it's a short lever, a short arc of motion. This is called forward sawing. You can also have your patient turn around and do what's called backward sawing. You can also do an exercise like this to start with for your abductors, where you hold a light weight, elbows bent, neutral rotation, and the patient is to abduct the arm about 45 degrees. With both this exercise and the sawing exercise, the technique is really important, and the patients need to be taught not to lead or to hike up with their shoulder, and to maintain proper posture the entire time. So internal and external rotation tubing exercises can begin in phase 2, but the range of motion should be kept from about 45 degrees of external rotation to neutral. We need to still be mindful and not to force into external rotation or move into any ranges that cause pain. 3 key instructions should be given with rotator cuff strengthening. The first is for the patient to set their posture, which includes setting the scapula. The second is to maintain the elbow at side, and a small towel helps to facilitate that. And then the third is at the wrist, to watch the wrist doesn't start to extend as the patient gets into a weak area and they start to compensate from that joint. The focus of scapular stabilization exercises in phase 2 is to begin adding distal mobility to the stable proximal segment. There's many ways to do this, even thinking about encouraging your patients to integrate scapular stabilization into day-to-day life activities. Some suggestions are things like walking, eating, working at the computer. So some physio exercises for scapular stabilization might be something like this, where you have the patient standing, they have their hand on a ball or onto a towel on a counter. The first step is, of course, setting that posture. Then the patient is instructed to set the scapula and to hold this position while they then move their arm slowly in all sorts of different positions on the ball. This exercise can be progressed to things like a ball on the wall exercise when the patient's ready, but remembering that this demands a lot more strength and control in the trunk and more range of motion. So adjusted as your patient is able to do this. So you can also do more traditional rowing type exercises to work retraction and depression. The most important thing here is the timing of those muscles that are contracting. So your first step is always posture, as we've said. Your next instruction to the patient is, without moving their arms, to pull the blades back into that position. To hold that position now, bring the arms back a little bit. Keep the blades still while the arms are released back, holding this, and then releasing the shoulder blades. It's really important that we teach patients on an exercise that's a little bit easier like this, how to establish that timing, because it becomes really important in our more difficult overhead exercises. So protraction exercises can be added in phase 2, and a really good one to start with is, again, with your patient supine, have them flex their arm to about 90 degrees, and then the instruction is to think about elevating the arm up or extending up. This should come from the shoulder blade. Watching, patients will want to use their upper traps and to try and cheat to hike that up, so you want to guide them to make sure that that's a straight up motion, so they can protract and hold and then release it back, get the feel of both the up and down. And after they get a good sense of how to do this, then you can add little circles to the end while they hold it in that up protracted position, writing the alphabet, any of those things. The same motion can be done now in standing, and so with the tube attached behind the patient, the instruction again is to try and extend the arm forward without lifting. So a little bit lower to begin with, and really thinking about that motion coming from the scapula, coming forward, and to hold. And then as they get stronger, again, you can add those little circles or figure eights or whatever you want on the end while they maintain the scapularly protracted position. Closed kinetic chain exercises are added during this second phase. These exercises work well as they can help with range, strength of the cuff and the scapular stabilizers, and patients feel very comfortable doing these exercises because their arm is well supported. There are lots of different ways to do closed kinetic chain exercises, but choices should always be made based on the patient being able to do the exercise properly without pain. Also remember that we can't do any exercise that places the patient's arm into that apprehension position of abduction and external rotation. A few examples include doing closed kinetic chain on a physio ball. Patient is taught how to maintain the posture, good scapular positioning, and then they add a little bit of light compression and some range of motion. You can also have your patient on all fours and maintaining that proper spine position. Have them again set scapula, and then just work on shifting weight forward and backwards. You can get a little bit of range of motion. They have to co-contract, and then side to side. And you can draw in as much or as little of that scapular stabilization as you'd like with this exercise. Closed kinetic chain exercises can also be done against the wall when the patient has the appropriate range and strength. Again, watching your technique, and you can have the patient going into a push-up type of motion. Good. And coming back, and you can add a little bit of protraction at the end there. Good. You can also do similar exercises, closed chain on the wall with a ball. All of these things work really well here.